In this presentation we will discuss the surgical anatomy of the spine as part of the supplementary material belonging to chapter number 4. The content of the presentation will be as follows. Starting with an overview of the anatomy, we will describe the body surface projection and palpable landmarks of the spine, followed by a description of the vertebral structures, relationship between vertebrae, and the muscles associated with the spine. We're going to follow with the cervical region, thoracic region, and lumbar region. The typical adult human spine has 7 cervical, 12 thoracic, 5 lumbar, 5 fused sacral, and 4 fused coccygeal segments. These segments carry the spinal cord and its 31 paired nerve roots. The upper 26 segments of vertebrae, with the help of the intervertebral joints, ligaments, and surrounding muscles, form a chain-like structure with strong support and flexible movement. The main functions of the spine are 3. Protect the spinal cord and thoracoabdominal organs in front of the spine, provide a structural support and balance to maintain an upright posture, and transmit the load from the upper body to the pelvis to the lower extremities, and finally, enable flexible motion. Let's start with the rest of the presentation.
In this 3D model, we're gonna get an overview of the body surface projection and palpable landmarks of different regions of the spine, from the cervical to the lumbosacral region. So let's start with the most superior portion, which is the squamous portion of the occipital bone. And we can easily identify the anion or external occipital protuberance, which is really helpful to differentiate between the supratentorial and infratentorial space, but also it's a good landmark for any posterior approaches to the craniocervical region. Something that we can notice from a posterior perspective and anterior perspective is that there's a transverse process that is prominent in this area, which is the transverse process of C1. The transverse process of C1, it is easily palpable, and it lies conventionally between the mastoid tip and the mandible. It lies at a midpoint between these two structures. And of course, it is a place just lateral to the vertebral artery, the horizontal portion of the vertebral artery. From a lateral perspective, we can see that there's a prominent spinous process, which is the spinous process of C2. The spinous process of C2 is the second prominent palpable structure just after the anion. And if we get an oblique view, we can identify the transverse foramina through which the vertebral artery travels. The transverse foramina conventionally are going to be in between 2 tubercles, one which is anterior and another that is posterior. So there's an anterior tubercle that is relevant for this, and it is a landmark because of being the most prominent one, which is the anterior tubercle of C6. So this is called the carotid tubercle because it lies just in between the vertebral artery and the carotid artery, and it's also called the Chassagnac's tubercle. So now moving inferiorly, what we see right here is the most prominent spinous process, which is the spinous process of C7. In about 75% of the population, this is the most prominent one, but there could be some individuals in which the spinous process of C6 or T1 is going to be the most prominent one. So it is not always a rule, like anything in anatomy, there are anatomical variations, but it's conventionally the most prominent in this region. Now, if we move inferiorly, we see the thoracic region. The thoracic region has several bony structures that are surrounding the area that can be used as anatomical landmarks. So in this case, what we're seeing here is the spine of the scapula, and just the root of the spine of the scapula conventionally serves as a landmark to find the spinous process of T3 because it lies at the same axial level. Now, if we move inferiorly, the inferior scapular angle conventionally lies at the same axial level of the spinous process of T8, usually between T8 and T9. And if we move anteriorly, what we see in this portion is the external angle, which it conventionally lies at the level of T4, and that's what we're seeing right here. So that's intervertebral between T2, T3, T3, and T4, and this points out directly towards the body of T4. And inferiorly, we see the ciphisternal junction that serves as a landmark for T9, the body of T9, what we're seeing labeled. More inferiorly, towards the lumbar region, there's the umbilicus conventionally lies at that level, at the same axial level of L3, but of course there's some body types and even weight that can modify this landmark, so it's not a very reliable one. Now, moving towards a posterior view, we see that there's an angle here that helps to identify T12, and that's the costovertebral angle, which is basically the junction between the most inferior rib and the body of T12. So that is called the costovertebral angle. Now, moving inferior towards the lumbar region, what we're seeing in this region is one of the most common landmarks used in spine anatomy, which is a supracristal line. This is again a very basic line that runs horizontally just superior to the superior margin of the iliac crest that are just right here. So it is historically known as a landmark for the spinous process of L4, but that's not always the rule, and actually in 75% of the patients or the individuals, it lies at the level of L3 and L4, basically at the same actual level of an intervertebral disc. So that's, again, there are anatomical variations. Sometimes this supracristal level is going to lie either posteriorly, superiorly at between L2 and L3, or inferiorly between L4 and L5. About the spinous processes of the lumbar spine, it is conventionally they are conventionally hard to palpate, and mostly for the most inferior approaches, meaning L4 and L5, because they're shorter than the rest of the spinous processes. More inferiorly, we see that it actually lies the most posterior projection of the spine, and that's gonna be it's gonna be characterized for a couple of by a couple of crests, being the most prominent ones, the median crests that are just at the midline. In order to characterize better the curvatures of the spine, we will remove the articulations of the spine column with other bony structures. So, from a lateral perspective, we can see that there are 4 curvatures, and starting with the cervical region that has lordosis, thoracic region is going to have kyphosis, and then the lumbar region, then it's going to have again lordosis, and the sacrococcygeal region with a kyphosis. So each one of these regions are going to have a different amount of degrees. Usually the cervical lordosis is going to be around 30 to 40 degrees. The thoracic kyphosis is going to be around 20 to 40 degrees. And the lumbar lordosis is going to be around 30 to 80 degrees. That is going to vary depending on gender and age.
Now let's go over the vertebral structures. In order to properly visualize these structures, we're going to isolate the typical vertebrae and put them side by side. It is important to remember that there are junctional vertebrae that are going to have characteristics of both the upper and lower regions. So again, what we're seeing here are the typical vertebrae of the cervical, thoracic, and lumbosacral regions. A vertebra is formed by 2 big components. One is the body, and the other is the vertebral arch, which lies posteriorly. Again, the body is has the shape of a cylinder, and it's going to change in its dimensions due to the amount of force that each region needs to handle with. The body is going to be connected by 2 bridges, which are the pedicles, with a structure that has more of a triangular shape named the vertebral arch. The vertebral arch encompasses different processes. This is better visualized from a posterior perspective. Let's go over the thoracic vertebra, and we can see that there are 4 articular processes, one right side on the right side, one superior on the left side, another superior, an inferior on the left side, and another inferior on the right side, articular processes. And laterally, we're going to see 2 transverse processes. If we move posteriorly, we can see the 7th process, which is spinous process. These processes are going to be connected by 2 laminae. And from superior to inferior, there's going to be a structure called the pars articularis, which is going to be connecting both the superior and inferior articular process, and it's going to be just posterior to the pedicle. Anterior to the laminae and medial to the articular processes, we can see the vertebral foramen, which is the place that in which we're going to find the spinal cord. Now again, all these structures and their features. We will compare them in the next couple of slides. There's several different characteristics that are going to help us to differentiate vertebrae from the same region, and of course the vertebrae from different regions. When we talk about the relationship between vertebrae, we should take into consideration not only the osseous components, but of course the joints, ligamentous components, and neurovascular structures that are involved in these relationships. So from this posterior view of the cervical region and upper thoracic region, we can visualize two of the three joint complex. In the complex that we're seeing here are the facet joints, one for each side, which are formed by this inferior articular process and the superior articular process of the adjacent vertebra. These joints are covered by a 1 to 2 millimeter thick layer of hyaline cartilage. The biomechanical function of each pair of facet joints is to guide and limit the motion between vertebrae. A little bit of the anatomy of this area from cephalic to caudal. We see the occipital condyle, the atlanto-occipital articulation or joint, the posterior arch of C1, the third segment of the vertebral artery, and this is an anatomical variation in which there's a osseous bridge covering the third segment, and that's called a ponticulus posticus. We see inferiorly the paravertebral venous plexus and the ligamentum flavum, which is gonna be present and attaching from lamina to lamina in this vertebrae. We see the bifid process of C2 as well as the long spinous process of C7 and T1. Now this is a lateral view of the cervical region, and again what we're seeing right here is the zygapophyseal joint or facet joint from the articulation of this inferior articular process and the superior articular process. What we're seeing also right here is the transverse process with two tubercles, meaning that we're drawing out at a subaxial level. There's an anterior and inferior tubercle, and there's an intertubercular lamella that is going to be connecting these two tubercles. There's a nerve that is going to be resting over the spinal nerve groove, and there are going to be two rami. One is a ventral and the other is a dorsal rami. And again, this is part of the axial and subaxial region of the spine. This is a posterior view of the lumbar spine, and again what we're seeing here is the zygapophyseal articulations. We're going to go over the different variations in the morphology and the features that make every region unique, but we can see clearly the inferior articular process and the superior articular process of the adjacent lumbar vertebra. Anterior to the lamina, we see the intervertebral foramen, and we also see the supraspinal ligament, which is going to be attached to the spinous processes. Anterior to the transverse process, we see the quadratum lumborum, and as we mentioned, from this side there's an intervertebral foramen. What we're seeing here is the exit of spinal nerve. Now the intervertebral disc is an important component for the interbody joint. There are 32 intervertebral discs, which account for 1/3 of the spine's height. They help to hold the vertebrae together and provide stability and absorb the shock. The components of each disc, which are the nucleus pulposus, and annulus fibrosus, and also the superior and inferior cartilaginous end plates have different compositions of proteoglycan, collagen, and water. Essentially, the nucleus pulposus, which is at the center, resists and redistributes pressure from the spinal column. The annulus fibrosus, which is at the periphery, is stiffer and tougher. It is composed of collagenous lamellae that are arranged around the nucleus pulposus like the plies of a tire. The outermost layer of the annulus fibrosus fuses with the periosteum of the vertebral body. So remember, the vertebral body is going to be just inferior and superior to the disc. And these bodies are going to be covered anteriorly by the anterior longitudinal ligament and posteriorly by the posterior longitudinal ligament. And these are going to be connective tissue that are going to be fused with the annulus fibrosus at their respective sites. So we can identify that this is lumbar region, a lower lumbar region. The reason is because we can see the cauda equina nerves in the spinal canal. We see this short and broad lamina and the Z joint that we mentioned previously. We also see the abdominal aorta and inferior vena cava. Now this is a lateral view again of the lumbar region, and this gives us a very nice perspective of different joints, what we call the three complex joint. Again, a facet joint and an interbody joint forming what resembles a tripod. We also see an intervertebral foramen that is going to have a roof and it's going to have a floor made of the notches of the pedicles. We remember there's an inferior notch and a superior notch. Usually in this lumbar region, the inferior notch is going to be more prominent. Now, there's a number of structures passing through the intervertebral foramen, and that includes from spinal nerves, the different segmental arteries, recurrent meningeal arteries and nerves, lymphatic tissue, and also there are going to be some transforaminal ligaments that might play an important role for the obstruction or compression of a nerve root. If we move anteriorly, we have the vertebral body that, as we mentioned in the previous slide, anteriorly is covered by the anterior longitudinal ligament, and posteriorly is going to be covered by the posterior longitudinal ligament. The annulus fibrosus, which is located at the periphery of the disc, is going to fuse anteriorly with the anterior longitudinal ligament and posteriorly with the posterior longitudinal ligament. And at the center, the nucleus pulposus. So what we're seeing here is an interlateral view of the subaxial region. This is the axis. Right here is going to be the atlas. And again, we see the third segment of the vertebral artery and the second segment of the vertebral artery. So there's a unique feature of the subaxial spine, which is this with an process which is lateral projection of the superior surface, and this uncinate process articulate with the reciprocal convex area on the inferolateral aspect of the upper body. Functionally, this oncovertebral joint, which is the articulation again, limits the lateral displacement of the intervertebral disc. And a little bit of anatomy. We're seeing the pedicle, the inferior notch, the superior notch, the groove for the spinal nerve, the pedicle of C4, and the intervertebral foramen. Let's move to the next slide. And so this is a cross section of the upper lumbar thoracic region, and what we're seeing here is or we can identify right here is the spinal canal. The spinal canal is the collection of the vertebral foramina. It is enclosed by the vertebral bodies anteriorly and the disc, and also the posterior longitudinal ligament, and posteriorly by the laminae and the ligamenta flava, laterally by the facet joints and also the pedicles. The spinal canal is an osseous and fibrous passage that contains the spinal cord, the nerve roots, and inferiorly at the level of L1 or below L1, L2, the cauda equina. There's also CSF, and there are gonna be membranes, as pretty much like in the brain, covering the spinal cord. There are gonna be the pia, the arachnoid, and the dura, which is the outermost layer. There's also there's gonna be venous plexus, and mainly in the lumbosacral region, there's going to be a high content of adipose tissue that is going to be filling the epidural space. Next. So what we're seeing here is a posterior view of the left side, the lumbar region. And what we can identify right here is the supraspinal ligament, the interspinal ligament, and in between the lamina, we can see the ligamentum flavum from the left side. We see the spinal nerve emerging from the intervertebral foramen. We see a plexus, a pain plexus, and we can see also a segmental artery, a transverse process, and around this area, surrounding or being part of intervertebral foramen, laterally, we see the transforaminal ligament. There are usually a number of transforaminal ligaments. It's not a single ligament. We see right here is a posterior view of the cervical region. This is C2, so this is C3 after a laminectomy on the right side. This is the bifid process of C2, and we can visualize the location or the relationship of the dural sleeve covering the nerve roots, the pedicle and inferior and superior notches of this case C4 and C3, and how anterior to the nerve root we can find the second segment of the vertebral artery. We see the ligamentum flavum, which again is attached to the inferior superior edge, to the superior edge of the inferior lamina, and is going to be attached to the inner portion of the inferior edge of the superior lamina. Now this is an anterior view of the craniocervical region, and we can identify a couple of big vascular structures. We see the right and left vertebral arteries, and these are going to be the occipital condyles. Again, this is an anterior view cross-section from a coronal plane, and this is the atlanto-occipital articulation. And what we see here is the anterior spinal artery, which is a branch formed by both vertebral arteries. We see the dural sleeve of the C2 nerve, and we're seeing over the condyle the hypoglossal nerve. So this is the hypoglossal canal. Superiorly, we see the jugular foramen with its neural content and vascular content. We also see the denticulate ligament that is gonna serve as an attachment. It's gonna emerge from the pia and it's gonna attach to the lateral portion of the spinal canal, and it's gonna help to stabilize the spinal cord. Now this is a posterior view. Again, the craniocervical junction, in this case the cervical medullary transition or region. And what we're seeing here is the posterior part of the posterior spinal artery and also the posterior spinal nerve. The posterior spinal arteries appear in pairs compared to the anterior spinal artery, and they also come from the vertebral artery conventionally. Sometimes they emerge from the posterior inferior cerebellar artery, and they descend along the posterolateral spinal cord and are reinforced by several posterior segmental medullary arteries along the way. So a little bit of anatomy that we see here is the posterior arch of C1 after removing part of it. We see the 11th nerve, we see the occipital condyle, and we see the mastoid, both mastoid tips, the cerebellum, transverse sinus, sigmoid sinus, and the transition between this vertical segment of V3 to a horizontal segment of V3. The muscles associated with the spine are important structures not only because of their biomechanical function and support to the spine, but also because of their involvement in the reconstruction and creation of corridors to reach different regions of the spine. In this model, we're gonna visualize the dorsal musculature from superficial to deep. This dorsal musculature can be divided into 6 layers, and starting with the most superficial layer, we have 2 big muscles. The superior one is the trapezius that attaches medially to C7 and runs inferiorly to the spinous process of T12, running anteriorly and lateral to the superior portion of the scapula and attaching right there. Now, inferiorly, we have this big superficial muscle, which is the latissimus dorsi muscle, and it also attaches to the spinous processes of T6 to the most inferior spinous processes of the lumbar region, which is L5. It runs superiorly and anteriorly and attaches to the inferior portion of the scapula and more laterally to the humerus. Let's remove this muscle and expose the rest of the deep layers, which are formed by muscles with smaller diameters and our dimensions. So let's start with the second layer, which is formed by the rhomboid minor and major, and anteriorly and superiorly by the levator scapular. So the rhomboid minor attaches to the spinous process of C7 and T1 and runs laterally to attach to the medial portion of the scapula, whereas the rhomboid major attaches to the spinous process of T2 to T5 and again runs towards the medial portion of the scapula. Moving anteriorly, we see that there's an inferior attachment to the scapula here by the levator-scapular muscle, and it runs superiorly and medially to attach to the transverse processes of C1 and C4. Okay, let's remove this group of muscles and expose the third group, which is formed by a couple of muscles named the serratus posterior muscles. We have a superior and inferior serratus posterior muscle. The superior serratus posterior muscle is going to be attached to the spinous process of C3 to T3, and it's going to run laterally and attach, and it's going to be attaching to the second to fifth rib, whereas the inferior serratus posterior muscle also attaches to the ribs and named the 9th to 12th rib, and medially it attaches to the spinous processes of T1 to L2. Let's remove this muscle and move towards the splenius capitis and splenius cervicis muscle. So the splenius capitis muscle is a muscle that attaches superiorly and anteriorly to the mastoid process of the temporal bone, and inferiorly and medially to the spinous processes of C7 to T3. And inferior to this muscle, we have the splenius cervicis muscle, which attaches to the spinous processes of T3, T4, T5, and T6, and runs superiorly and medial to attach to the transverse processes from C1 to 3 to C4. Let's remove this group of muscles. And now we have a deeper layer of muscles, which is the fifth and sixth layer of muscles. These layers encompass or are formed by a group of small muscles that are going to be running from the most inferior regions to the most superior regions. And the fifth layer is formed by a group of muscles that is named the erector spinae. The erector spinae muscles are muscles that are attaching from the occipital and temporal regions, in this case the mastoid process, to the transverse processes of different regions, and also the spinous processes. So these groups of muscles are the iliocostalis laterally, the longissimus more medial, and the spinalis muscles lying practically at a sagittal level. The iliocostalis muscle, which is the most lateral group of muscles, is formed by a thoracic segment, a lumbar segment, which is more inferior, and a cervical segment, whereas the longissimus muscles are formed by a thoracic group of muscles, a cervical group of muscles, and the most superior projection of these muscles, or attachment of these muscles, which are the longissimus capitis muscles. And this has an attachment to the mastoid process of the temporal bone. Medially, we have the spinalis muscles that are going to be divided into the cervical region and thoracic region, as well as the most superior region that goes from C7 to T6 to the superior nuchal line and inferior nuchal line, which is the spinalis capitis muscle. So if we remove this, we're gonna get a view of the deepest layer, which is formed by the semispinalis muscle and the multifidus. So the semispinalis muscle, at least one with it's gonna be the biggest of this deep layer of muscles, the sixth layer, is the semispinalis capitis. This muscle runs from the transverse process of C7 and T6 to the superior and inferior nuchal line, whereas the muscles that are running from the lumbar region to the cervical region, called multifidus, are muscles that are going to be attaching from the spinous process, the most anterior portion of the spinous process, to the transverse process, and that goes from one transverse process and attaches to 1 to 2 segments superior to the spinous process. Now if we remove this deep layer and we move towards the lumbar region, the first muscle that we're gonna find right here is the quadratus lumborum muscle. And this is important, at least for a 360 understanding of different ways to approach the lumbar region. We remove this quadratus lumborum muscle. What we're gonna visualize is the psoas muscle. So basically, this muscle, you can see, it is attaching medially to the transverse processes and even part of the body of the lumbar vertebrae, and the attachments of this muscle and the muscle itself lies anterior in a coronal plane, lies anteriorly to the lumbar plexus, the exit of the lumbosacral nerves, and this is going to serve as a muscle that is protecting these nerves. And inferiorly, another big muscle that is gonna be part of, or is gonna be associated with the stability of the sacroiliac junction, is gonna be the iliacus muscle. Continuing with the muscles associated to the spine, we have right here an anterior view of the axial and subaxial region. We can identify the hyoid bone lying at the same axial level of the body of C3. Superiorly, we see the suprahyoid group of muscles from medial to lateral, the genohyoid muscle, the anterior belly of the digastric, the mylohyoid muscle, stylohyoid muscle with a superior attachment to the styloid process. Laterally, the posterior belly of the digastric muscle that is going to have an attachment on the digastric group, which lies just medial to the mastoid tip. Inferiorly, we have the infrahyoid group of muscles from medial to lateral, the sternohyoid muscle, the thyrohyoid muscle, and the omohyoid muscle, which runs from posterior, lateral, and inferior to anterior, medial, and superior in an oblique fashion. And this is a relevant muscle when we're aiming to approach the cervical region from an lateral corridor, and sometimes can be on our way when reaching any region below C4 or C5. We're seeing all this after removing the platysma and removing the sternocleidomastoid muscle. In a deeper plane, what we see right here is from medial to lateral the longus colli that has three parts: a superior oblique part, a vertical part, an inferior oblique part. The superior oblique part, or the most superior attachment, happens at the anterior tubercle of the anterior arch of C1, and laterally we see the longus capitis that lies just lateral to the longus colli. It has an attachment over the basilar portion of the occipital bone. In a deeper layer, we see the rectus capitis anterior, and laterally the rectus capitis lateralis, connecting from C1 to the basilar and lateral portions of the occipital bone. We can also see the vertebral artery, the right vertebral artery, that is going to enter the transverse foramen at the level of C6 conventionally. This is an anterior view of the abdominal muscles. We see the external oblique muscle that has an origin on the lower 8 ribs and attaches, because right here in this dissection we remove partially this muscle. It attaches to the kyphoid process, and also has an inferior attachment over the anterior 2/3 of the iliac crest. In a deeper layer, we see the internal oblique abdominal muscle that has an attachment inferiorly over the anterior 2/3 of the iliac crest, and also a superior attachment on the lower 3 to 4 ribs and kyphoid process. It has a medial attachment on the pubic crest. And superficially, we see the rectus abdominis muscle that runs from superior to inferior. It attaches inferiorly on the pubic crest, and also has an attachment over the anterior pubic ligament. Superiorly has an attachment on the kyphoid process and part of the costal cartilages from the lower 5 to 7 ribs. The inferior to, or in a deeper layer, we see the transverse abdominis muscle that runs, as the name says, it runs in a transverse fashion from the pubic crest to the anterior pubic ligament. It has an attachment over the kyphoid process and also the costal cartilages of the lower 5 and 7 ribs. In between these two, the rectus abdominis and the transversus abdominis, there are going to be epigastric neurovascular components that are relevant during an anterior approach to the lumbar or lumbosacral region. We have right here the umbilicus, which is serves as a reference and is usually aligned with the body of L3, L4. The occipital bone is formed by 3 different regions: the squamous region, lateral region, and basilar region just at the center. From the endocranial perspective, or an endocranial view, we can identify several landmarks. In this case, we're going to start with the internal occipital protuberance that is going to lie at the same axial level of the external occipital protuberance. And then we have the impressions of big vascular components that are going to be lying over the occipital bone, in anteriorly and superiorly, probably. What we're seeing is the superior sagittal sinus, and inferiorly is impression of the occipital sinus. Laterally, we're going to have both transverse sinuses running over the squamous portion of the occipital bone, and this impression is going to help us to identify the infratentorial and supratentorial spaces. And just anterior to the squamous portion, we see the foramen magnum, which lies in between the 3 regions of the occipital bone. What we're seeing here is the jugular notch, which is formed by the projection of the jugular tubercle. It's basically the anterior limit of this tubercle. Anterior and medial, we're seeing the hypoglossal canal, also called the anterior condyloid canal, and we see in each one of these two lateral regions the condyles. So the condyles are gonna be part of the occipital-atlantal joint, and the condyles are ovoid structures that are going to be running from posterior and lateral to anterior and medial. And as I mentioned previously, there's going to be an anterior foramen, which is a hypoglossal foramen, and it usually lies between the junction of the first and second third of the condyle. Posteriorly, what we see here is the condyloid canal, which is the place through one of the emissary veins are going to be traveling. And as previously mentioned, on the lateral region, we're going to find the jugular process that in its anterior segment is going to have the anterior notch, which is the posterior portion of a jugular foramen. Just to remember that jugular foramen is the place where the internal jugular vein and the inferior complex named 9th, 10th, and 11th cranial nerves are going to be traveling through, and the jugular foramen lies posteriorly and slightly lateral to the hypoglossal canal. Now moving to towards an posterior extracranial view, we see that there are several landmarks related to muscular and ligamentous attachment. These landmarks can be identified thanks to protuberances as well. And from an inferior perspective, we see that the inferior nuchal line it can be identified, and superiorly we see a superior nuchal line. Superior to that nuchal line, we have the highest nuchal line. Just in the midline, we have the external protuberance, also called the anion, and medially there's going to be a medial nuchal line. And that's an overview of the occipital bone, which is going to be part of the craniocervical junction. Lying in a transitional region provides unique characteristics to the atlas, which is formed by two arches, an anterior and posterior arch, separated by lateral masses which have transverse processes. The anterior arch has protrusion, also called an anterior tubercle. This is the place that is going to serve as an attachment point for the anterior longitudinal ligament and the superior oblique fibers of the longus colli. Then we have the posterior arch, which from a superior perspective we can see that the posterior arch forms the posterior 2/3 of the circumference of the vertebral foramen. The posterior arch also has a tubercle, which is the posterior tubercle. The posterior tubercle serves as an attachment point for the rectus minor muscle and the occipital membrane. Both ligamenta flava also attaches to the inferior borders of this region. Laterally, we're going to have two groups, which are also called sulcus arteriosus. These two groups are as a place where the vertebral artery, the third segment of the vertebral artery is gonna be resting on, and it is important to analyze this area if any approach involving the vertebral artery is planning to be taken. Around 32 to 37% of the times there could be a bone made of bridge covering the artery called ponticulus posticus. Now, anteriorly, we have the superior articular surface and the inferior articular surface. The superior articular surface forms the atlanto-occipital articulation or joint, and it has a bigger diameter and a more and runs in a more oblique way, having a broad, larger base posteriorly and a smaller anterior diameter, and that's due to the shape of the occipital condyles. And we move inferiorly, and if we move inferiorly, we see that the inferior articular surface, which is going to be the place for the articulation between atlas and axis, it is running, or it has a more parasagittal direction, and in between these two articular surfaces, we're going to have this, which is the lateral mass. The lateral masses can be found between the anterior and posterior arches, and these are also the weakest points of the vertebra, and it's commonly it's a common place for fracture called Jefferson's fracture. Medial to this structure, we have the colliculus atlantis that serves as an attachment for the transverse ligament. Posterior to the colliculus atlantis, we have the sulcus atlantis that is foramen where one of a branch from the vertebral artery is going to be traveling through, and is going to be providing blood supply to the lateral masses of C1. Lateral to the lateral masses, we have the transverse foramen, and more laterally, we have the transverse process. As we mentioned previously, the transverse foramen is going to be a foramen through which the vertebral artery is going to be traveling through. It's going to go from a more vertical direction, oblique, around 45 degrees, and then it's going to make a turn after passing through this foramen, and it's going to take a more horizontal direction. Something particular about the transverse process of C1 is that it only has one tubercle, whereas the other cervical vertebrae are going to have an anterior and posterior tubercle. The atlas has also unique anatomical features. Starting anteriorly from the body, there's a superior projection named odontoid process or dens. If we move superiorly, we're going to find the apex of the odontoid process, and if we move anteriorly, the anterior articular facet, and posteriorly, the posterior articular facet. So anteriorly, the anterior articular facet articulates with the posterior articular facet of the anterior arch of C1, whereas the posterior articular facet is going to serve as a place for the attachment of the transverse ligament. Moving superiorly and laterally, we see these two protrusions that are going to be the place for the attachment of both alar ligaments, right and left, and superiorly again the apex of the odontoid process, which is going to be the attachment point for the apical ligament. Now moving laterally, we have the superior articular surface, which is which has a big surface that is running obliquely from lateral to medial, and it has a more horizontal direction than the inferior articular surface that it lies more vertically, and is practically emerging from the junction of the lamina and the pedicle. The pedicle lies just posterior to the superior articular process, and in between both articular processes, the superior and inferior, we have the pars interarticularis. Moving posteriorly, we have the lamina, and the lamina it's thicker than the rest of the subaxial lamina, and anteriorly we have the spinal canal or the vertebral foramen, and both lamina are joined by the spinous process, which is a bifid spinous process and is the second most prominent spinous process of the cervical region. Inferiorly, we have the inferior surface of the body of C2 that has an anterior projection for the interbody articulation with C3. Laterally, we have the transverse process, which is shorter and smaller than the transverse process of the rest of the cervical vertebrae. Medial to the transverse process, we have the transverse foramen, which is the place in which the vertebral artery is going to follow a medial lateral angle, and it's going to travel towards the most superior transverse process of C1. What we see right here is a 3D representation of a typical vertebra. This is C4, and first we can see the vertebral body, which is a small vertebral body with a broad coronal diameter. This is the superior end plate, the inferior end plate, and the superior end plate is going to have two lateral projections, which are the uncinate processes. These processes are going to be just medial to the vertebral artery, which is going to run through the transverse foramen. Posteriorly, we have the vertebral arch, which is connected to the vertebral body by the pedicles, and anterior to the pedicle we have the transverse process that has an anterior tubercle and posterior tubercle. In between these tubercles we see the connection happening by an intertubercular lamella. Just posterior to the intertubercular lamella we see a groove, which is the spinal groove. It is a place which a spinal nerve is going to be resting on. Superior to the pedicle we can identify the superior vertebral notch, inferiorly the inferior vertebral notch. Posterior to the pedicle we see the superior articular process and the inferior articular process, both running from inferior and posterior to anterior and superior. In between these articular processes there's a mass, which are both lateral masses, and posterior to the lateral mass we can identify the lamina. Both laminae are going to be connected by a spinous process. From a superior view we can identify the spinal canal or vertebral foramen, which has a triangular shape. And that's the anatomy of a typical cervical vertebra. Now we're gonna go over the characteristics of another unique cervical vertebra, which is C7. Starting out with the body, which since this is a transitional vertebra, we see that the transverse diameters tend to get larger than the sagittal diameter, and it preserves the unique characteristic of an uncinate process that again lies just medial to the vertebral artery, which is going to travel through the vertebral transverse foramen. And moving posteriorly, we have the vertebral arch, which is going to be connected again by these short pedicles. And anteriorly, this very small and thin transverse process with an anterior tubercle connected by an intertubercular lamella and a prominent posterior tubercle. Again, the intertubercular lamella is going to be the lateral limit of the spinal nerve groove. And if we move medially, the spinal nerve root is going to be coming out of the superior ventral notch. And at the inferior portion of the pedicle, you can see the inferior vertebral notch. Now, the superior articular process and the inferior articular process, they tend to go in a more coronal direction, meaning that they tend to go more vertical than the upper segments of the cervical region. And another apart, we already mentioned also the lateral mass, which is in between the superior articular and inferior articular process. But moving posteriorly, we see that the lamina tends to go shorter, and that's also one of the things that we're gonna see in the inferior levels of the that are gonna be part of the thoracic region, as well as this prominent spinous process. So that means that what we're seeing here is the articular processes tend to get a more coronal projection, again meaning more vertical. The lamina tend to get shorter, but the spinous process is gonna get longer. And as we're gonna see later on, the thoracic region, they're gonna tend to go more vertical as we move to the inferior levels. So again, the spinous process of C7 is the most prominent process, the most prominent spinous process of the cervical region, and is usually a landmark that can be palpable at the physical examination. Another thing that is worthwhile to mention is, and this can be found regularly on C7, is the absence or the atresia of the transverse foramen. If we remember, the transverse foramen of C7, it usually lies inferior to the axis of the vertebral artery to the conventional level, which is the transverse foramen of C6. So that means that usually these foramina are not hosting any vessel or nerve, and that's why a lot of times the foramen, one of the foramina or both, are gonna be closed or small, and that's the anatomy of C7. This 3D model offers an overview of the ligaments related to the odontoid process. So let's start with the cruciform ligament that is formed by a transverse ligament that is attaching to, it's going to be attaching to the colliculus atlantis, from colliculus atlantis to colliculus atlantis of C1. And it's going to be, this cruciform ligament is going to have a superior longitudinal and inferior longitudinal band. The superior longitudinal band attaches inferiorly to the transverse ligament itself and runs towards the basilar portion of the occipital bone, whereas the inferior longitudinal band attaches superiorly to the transverse ligament and inferiorly to the posterior surface of C2. Then anteriorly and running in an oblique direction, we have the alar ligaments. These ligaments are going to be attaching to the posterior lateral aspect of the odontoid process, and going to be running laterally and attaching to the occipital condyles. These ligaments are going to serve, or are going to help to limit the contralateral axial rotation. And anterior to the superior longitudinal band, we have the apical ligament. The apical ligament attaches to the posterior surface of the odontoid process and runs anteriorly to the bastion, where it merges with the fibers of the superior longitudinal band of the cruciform ligament. And this ligament prevents the vertical translation and anterior shearing of the occipital bone. In this area, particularly the apical, where the apical ligament and the superior longitudinal band and atlanto-occipital membrane lie, we can find a structure called the apical cape, which is an area covered by neurovascular structures such as venous plexus, recurrent meningeal branches of C2 and C1, and the apical odontoid arterial arcade. Great. This 3D model allows us to explore the craniocervical junction at from a posterior perspective, and the main neurovascular components, as well as the suboccipital group of muscles. So let's start identifying the osseous components. What we see here is the posterior arch of atlas. Inferiorly, we can identify the lamina of the axis and the bifid spinous process of the axis. Moving superficially and superiorly, we're going to identify superficial nerves. Medially, the greater occipital nerve, which is going to be coming out of the dorsal ramus of C2. And laterally, the lesser occipital nerve, which is going to be coming out of C2 and C3. Superiorly, we visualize the inium, which is external occipital protuberance, and lies at the same axial level of the superior nuchal line. And also we see the most superficial segment of the occipital artery, in this case the right and left occipital arteries. This is a great opportunity as well to identify properly the course of the proximal portion of the occipital artery, also the suboccipital portion of the occipital artery, lying in between the posterior belly of the digastric muscle and the superior oblique muscle. What we're seeing here is, after removing the right lamina of C3, is the exposure of the dura and the dural sleeve covering the nerve root. And now we move towards the suboccipital muscles. And just to remember as well, in this region we're going to find the posterior atlanto-occipital membrane, which runs from the posterior arch to the opisthum, which is the posterior portion of the foramen magnum. What we're seeing here is the rectus capitis minor, which is going to have a superior attachment on the inferior nuchal line and inferior attachment on the posterior arch of C1. Laterally, we have the rectus capitis major, which is attaching superiorly to the inferior nuchal line and inferiorly to the spinous process of C2. If we move laterally, we see the obliquus capitis superior muscle, which is attaching to the most lateral portion of the inferior nuchal line and has an inferior attachment on the lateral mass of C1. Inferiorly, you can identify the obliquus capitis inferior, which is attaching superiorly and anteriorly on the lateral mass of C1 and posteriorly on the spinous process of C2. So after defining the muscles, we can identify the suboccipital triangle and the structure that encompasses or that are within this triangle. One of the major structures is the V3 segment of the vertebral artery, and we can identify here the sulcus arteriosus of the atlas and the horizontal portion of the vertebral artery. Just posterior to the vertebral artery, we're going to find the C1 nerve root or the suboccipital nerve, and we can also see some branches from the occipital artery that are usually forming an anastomosis with the vertebral artery. It's important to remember that there's also vertebral plexus in this region that is likely to bleed when exposing this area. From the other side, we can identify the right vertebral artery. Again, V3 segment with a horizontal portion and a more vertical portion that is going to be coming out of the transverse foramen of C2 and entering the transverse foramen of C1. Right here, we've seen the transverse process of C1, and it's going to rest over the sulcus arteriosus. Inferiorly, we see the C2 nerve root, and we can see the C3 and its connections with C2 to form the lesser occipital nerve. This is a posterior view of their coronal cross-section of the craniocervical junction. What we're seeing right here, this is the anterior edge of the foramen magnum. After removing the superior longitudinal and inferior longitudinal bands, we can identify part of the cruciform ligament, which is composed by a transverse ligament. This transverse ligament goes from colliculus atlantis to the quadrilateral colliculus atlantis, passing behind the odontoid process. Superiorly, we see the alar ligaments that have insertions at the posterior lateral aspect of the odontoid process and run laterally to the medial surface of the occipital condyles. Anteriorly, we see the apical ligament that attaches superiorly to the bastion or the anterior edge of the foramen magnum, and it merges with the superior longitudinal band as well as the anterior longitudinal ligament. Let's move to the next one, and this is a mid-sagittal view of the craniocervical region. So from anterior to posterior, we can identify the anterior arch of C1, the odontoid process, the body of C2, and the posterior arch of C1. This is the cervical medullary junction, the cerebellum, clivus, And from the connective perspective, we see the longus colli that, if we remember, the longus colli attaches to the anterior tubercle of the anterior arch of C1. And superiorly, we see the longus capitis that attaches to the basilar portion of the occipital bone. In terms of ligaments, we can identify the anterior longitudinal ligament lying anterior to the anterior portion of the body, and at the posterior portion of the body, the vertebral body, we see the posterior longitudinal ligament. If we move superiorly, this longitudinal ligament becomes the tectorial membrane, and anteriorly, the anterior longitudinal ligament becomes the anterior atlanto-occipital membrane. Posteriorly, we have the posterior atlanto-occipital membrane. A couple of the ligaments that we mentioned previously, but now from this mid-sagittal perspective, we see the apical ligament that attaches from the apex of the odontoid process to the bastion, and we also see the alar ligament that attaches to the medial portion of the condyles, and posterior to it and inferior we see the transverse ligament, which forms the cruciform ligament along with the superior and inferior bands. This is a lateral view after removing the muscles of the subaxial region and part of the craniocervical region as well. And what we're seeing right here from anterior to posterior and superior, we see the posterior valley of the digastric that is going to be attached to the digastric groove. And if we follow that digastric groove, anteriorly we're going to find the stylomastoid foramen, and we're seeing the extratemporal portion of the facial nerve in this region. Now, lying medial and posterior to the posterior valley of the digastric, we see the hypoglossal nerve. This hypoglossal nerve is going to have some anastomosis with the cervical plexus that goes from C1 to C4. And a couple of arteries that we're seeing here in providing blood supply to the thyroid is the superior thyroid artery, and providing blood supply to the larynx, it's the superior laryngeal artery. We see also the superior laryngeal nerve, which is a branch of the vagus nerve. We see the common carotid artery, the external carotid and the internal carotid arteries, the cervical sympathetic trunk that travels along these arteries, as well as the internal jugular vein and retromandibular vein that are going to be posterior and lateral to the arteries. Going posteriorly, we see the sulcus arteriosus, V3, the transverse foramen. Around here should be the root of C1. This is C2 with a dorsal and ventral rami, and this is C2 and C3. These two nerves are going to form laterally the lesser occipital nerve, and C2, the dorsal branch, is going to form medially the greater occipital nerve. After reflecting superiorly the major neurovascular content, what we see here is part of the cervical plexus that again goes from C1 to C4. This plexus is going to have a series of connections with the hypoglossal nerve and the spinal accessory nerve. We see from C4 the phrenic nerve running inferiorly, and from C5 to T1 we see the trunks of the brachial plexus being formed. We see the subclavian artery and the thyrocervical trunk giving origin to the inferior thyroid artery. We remember the superior thyroid artery comes out of the external carotid artery, and the ascending cervical artery. Moving medially, we can see the vertebral artery, and we see that this vertebral artery is actually entering the transverse foramen above C6, which is an anatomical variation. It usually travels through the transverse foramen at the level of C5, and what we're seeing here is the anterior tubercle of C6, or tubercle of Chassaignac, and medial to that, we're seeing the longus capitis. The longus coli have been cut and also reflected. We see the trachea, and we see the esophagus and trachea, and also we see the recurrent laryngeal nerve, bodies, and intervertebral disc of C4, C5 to C7, and even T1. An anterior view of the craniocervical junction and also part of the subaxial region. Medially, we see the anterior longitudinal ligament that is going to become more superiorly the anterior atlanto-occipital membrane, and this ligament is going to be attached to the anterior portion of the vertebral bodies. Over this ligament, we have the longus coli, that again, the superior oblique part of the longus coli is going to be touching superiorly to the anterior tubercle of C1, and laterally we have the longus capitis attaching more superiorly on the vascular portion of the occipital bone. We see the V2 segment of the vertebral artery traveling through the transverse foramen. We see the anterior tubercle and posterior tubercle of the transverse processes, nerve roots, and we see the V3 segment of the vertebral artery. After removing the disc, we can identify better the uncinate process, and this superior region we see the oncovertebral joint, and more posteriorly we see the dural sleeve of C5, and we also see the posterior longitudinal ligament, which is going to be attached to the posterior region of the vertebral body. This is a posterior view of the craniocervical junction. We see the posterior arch of atlas, the bifid process of axis, transfer process, this long transverse process of C1, the V3 segment, and we also see anterior to the V3 segment, this horizontal portion, we see the nerve root of C1, or the suboccipital nerve. Something interesting about this specimen is an extradural origin of the posterior inferior cerebellar artery, which is something that could be a variation that need to be taken into account while doing any craniocervical approach, since this is a very important blood supply for the elements or the structures in the posterior fossa. And what we're seeing here, this is medial, this is lateral. So this is a view of the upper subaxial region. We're seeing the submandibular gland superiorly. This is going to be the ramus of the mandible, and we see the infrahyoid muscles from medial to lateral, the sternohyoid and the thyrohyoid muscle. We see the superior belly, or the superior portion of the homohyoid muscle. Laterally, we see the common carotid artery, and we also see the bifurcation, usually at the level of C3, C4 of the internal carotid artery and external carotid artery, and one of the early branches of the external carotid artery, which is the superior thyroid artery. We see laterally the internal jugular vein, And we also can identify the posterior belly of the digastric. Medial and posterior to that, we see the hypoglossal nerve, which is going to give up a branch for the thyroid and genohyoid muscles. And deeper, in a deeper field, we can identify the superior laryngeal nerve, which is a branch of the vagus nerve. And we can also outline the carotid triangle, which is formed anteriorly or medially by the superior portion of the homohyoid muscle, laterally by the medial edge or border of the sternocleidomastoid muscle, and superiorly by the inferior edge of the posterior belly of the digastric. Deeper in this portion, we see the prevertebral fascia. So along this area, we're going to find the esophagus and trachea that will need to be displaced medially, and the vascular components will need to be displaced laterally in order to properly expose the bodies of the subaxial region. So let's explore quickly an actual cut at the upper subaxial level, meaning what we're seeing here is the body of C7. It's going to start with identifying structures anteriorly, starting with the mandible, moving posteriorly to the root of the tongue, the epiglottis, and the pharyngeal constrictor. It's important to comment that the upper portion of the pharyngeal constrictor is attached to the pharyngeal tubercle of the basilar portion of the occipital bone. This is a great view to understand the different neurovascular and visceral components when approaching either anteriorly or posteriorly, in this case the upper subaxial level. So let's go back to the anatomy, and lateral to the root of the tongue, and just medial, in this case, to the submandibular gland. What we can see here is the hypoglossal nerve that it is worthwhile to remember that there's a communication of this nerve with the cervical plexus via the ansa cervicalis. And again, just posteriorly, we're gonna start identifying vessels with big caliber, starting with the retromandibular vein, which is a direct branch of the jugular vein. We see the internal jugular vein laterally, and medially we can identify anteriorly the external carotid artery and posteriorly the internal carotid artery. Just in between these vessels, the internal jugular vein and both carotid arteries, we can identify the vagus. And let's also just mention, if we remember, we when we were visualizing the anatomy of the occipital bone, we identified the jugular notch, and the most posterior portion of the jugular foramen is the vascular portion, meaning that the internal jugular vein is going to travel posterior, and then it's going to go lateral to the neural component, that is the inferior complex, and we also know that the vagus nerve forms part of the inferior complex. So let's move medially, and what we can see here is the sympathetic trunk, which is usually like in a very intimate relationship with the carotid artery. In this case, we separate a little bit the structure just to properly identify them. And moving medially towards a muscular compartment, but we saw laterally there was a vascular compartment. we see the longus colli, that if we remember, the superior of attachment of the longus colli is going to be at the anterior tubercle of the atlas. Now, lateral to the longus colli, we have the longus capitis muscle, and then we move posteriorly to identify the superior articular facet of C4. What we see right here is the left vertebral artery and right vertebral artery. One of the muscles that we explored before during the musculature or the muscles associated with the spine is the semispinalis capitis that we mentioned lies at a deep layer. The splenius capitis muscle and the longissimus capitis muscle, which lies more superficially. And one of the muscles that serves as a landmark for anterolateral approaches, the sternocleidomastoid muscle. So this is a muscle that is usually retracted, but let's remember that there's an intimate relationship between this muscle and the spinal cranial nerve, the 11th nerve. And it is conventionally this route, the one that is taken just anterior to the sternocleidomastoid muscle, separating laterally the vascular component and mobilizing medially the visceral component, in this case the trachea and the esophagus, in order to reach the anterior portion of the cervical region. In this 3D scene, we can see the thoracic vertebrae at different levels, with vertebrae from transitional regions named T1 and T10, and typical thoracic vertebra, which is T5 in this case. So let's start with the typical thoracic body, vertebral body, that conventionally has this heart shaped from superior perspective. And we can see, if we move towards the upper level, that the diameters and dimensions are going to change from upper to lower levels. And that's the reason of this characteristic shape, which is due to the increase on the surface of the end plates, mainly the increase on the anterior to posterior dimensions. And later on inferior levels, there's a general increase on the dimensions, acquiring more lumbar morphology. If we move posteriorly, we see the pedicles is outlined as number 2. So the pedicles are gonna have initially a more oblique projection, and then are gonna tend to get stronger and have a more parasagittal projection on inferior levels. And that's also gonna modify the spinal canal or the vertebral canal, in which we see that it tends to be smaller and more rounded on inferior levels compared to the superior ones. Some of the characteristics of the thoracic vertebral bodies is that they have demifacets, which serve as articulations with the ribs, at least the most medial articulations with the ribs. There's a superior and inferior demifacet on a typical thoracic vertebral body, and there's another lateral articulation, which is the costotubercular facet, which lies at the anterior aspect of a transverse process. So we can identify again superior and inferior demifacet on T5, as well as a superior demifacet of a more that resembles the superior demifacet of T5, on T1, and a very small inferior demifacet again on T1. If we move towards L5, we can identify again a superior demifacet and identify an inferior demifacet that has a smaller surface compared to T5. Now, seeing the transverse processes, we see how the transverse process of T1 has a more superior projection, whereas the transverse process of T5 has a more horizontal projection. It tends to get broader and shorter. And if we move towards the inferior level, we see that it goes considerably shorter and also thicker. Now, identifying the laminae and the pars interarticularis, we see that the lamina of T1 has a more horizontal projection, whereas the lamina of T5 tends to get shorter and have a more vertical projection. And when we visualize the lamina of T10, we see that it's really short compared to T1. The superior and inferior articular processes on all at different levels tend to be or to have a more vertical projection, and they're usually are matching the superior and inferior segments, as we can see again from T1 that tends to go a little bit more anterior, and see on T5 and again T12, T10, and identifying the most posterior projection, which is the spinous process. At an inferior level, we see that the spinous process gets shorter and have a slight posterior or horizontal projection, whereas in this typical spinous process of the thoracic region, we see that it tends to be has a long projection and runs in a more vertical fashion. And we see T1 that has a long spinous process and has a more horizontal projection. Let's remember as well that sometimes this tends to get even a more posterior projection than C7. So that's the overview of the different morphology of the thoracic vertebrae. This is a dissection exposing the right side of the mid-thoracic region, from superior to inferior, again left side and right side, medial to lateral. What we're seeing superficially are the first layer of dorsal muscles that are associated with the spine. We see the supraspinous ligament, and in a deeper layer we see the interspinous ligament. We can identify the spinous processes that have a vertical projection and the laminae of this right side with a very, very small space between the laminae. We also see the transverse process, and if we remember, the transverse process has a facet for the articulation with the body of a rib, and this facet in between we're going to find a costotransverse ligament. After removing the lamina, we can expose the dura mater, and we also expose the dural sleeve of the intercostal nerve root. We see that the nerve root has a dorsal and ventral rami, and that the dorsal rami is going to travel over the superior edge of the rib. Anteriorly, we see the costal demi-facet, and we also see the interbody space with the intervertebral disc. We can identify the bodies, and anterior to that, we can also identify the pleura. This is a posterior view from superior to inferior, medial to lateral. We can visualize the superficial trapezius muscle that is attaching to the upper thoracic and cervical spinous processes, as well as the latissimus dorsi muscle that attaches to the mid and lower thoracic spinous processes. After removing the superficial muscles, we can expose the lamina, visualize as well the transverse process and its articulation with the body of the rib, the dorsal rami running over the superior edge of the rib, and in between these ribs we can observe the intercostal muscles that are muscles that help for the respiratory function. We can again identify the consotransverse ligament as a ligament that lies just at the joint between the anterior portion of the transverse process and the posterior portion of the body of the rib. A close-up view, superior, inferior, medial to lateral, from deep to superficial, the pleura, the intercostal artery. The intercostal arteries are branches that originate from the thoracic aorta from the 3rd to 11th segments. The thoracic aorta lies at the mid left parasagittal portion of the vertebral body, meaning that the right intercostal artery has a longer course compared to the one in the left side. We can also see that the intercostal artery travels along with the intercostal nerves that, as we mentioned before, are going to be traveling over the superior edge of the rib. We see the transverse process, the inferior articular process, superior adjacent articular process, the zygapophyseal joint, lamina, the intervertebral foramen being exposed, the vertebral bodies and interbody space with the disc, and of course the spinous processes with their respective ligaments. This is a 3D scene depicting 3 different lumbar vertebrae, L1, L3, and L5. From a superior view, the bodies are large and kidney-shaped with a concavity facing posteriorly. On the posterior rim of the superior end plate of the vertebral bodies, there are small elevations that represent remnants of the uncinate processes of the cervical region. The lumbar vertebral bodies are wider from side to side than from anterior to posterior or front to back. The L4 and L5, in this case L5, present taller bodies in the front than in the back, and that has a significant impact for the lordosis of the lumbar region. 90% of the compressive load received by the vertebral bodies are carried by the inner cancellous bone, just in the center of the body. Moving posteriorly, labeled as number 2 here, number 3, and number 4, we can identify the strong and short pedicles that are part of the lumbar vertebral structures. These pedicles, again, are short and they're attached a little bit more inferior to the body than the ones in the thoracic region. They have two notches. One is a superior notch and an inferior notch. The inferior notch tends to be more prominent than the one that lies superiorly. From a superior view, we can see that there's an actual orientation that is going to change as we move towards lower levels. Usually at the level of L1, there's an actual angle of around 5 degrees that increases 5 degrees for each one of the segments, ending at approximately 25 degrees with a 25 degrees action angle for L5. Now, labeled as number 7, we see the transverse process of L1. The transverse processes of the lumbar vertebrae project posterolaterally from the junction of the pedicle and the lamina. The lumbar transverse processes are long, and if we see the three of them, the transverse processes of L3 are the ones that have the longest transverse length, that lie around 5 centimeters from the midline. Now there's a feature that is unique for this transverse, for this region, which is a prominence that emerges from the posterior and inferior portion of the transverse process at its junction with the lamina. This is the accessory process. The accessory process serves as an attachment site for the longissimus thoracis and the medial intertransversae lumborum muscles. Now, labeled as 9, we see the superior articular process. The superior articular processes are similar to the thoracic region in terms of their vertical orientation, and from a superior perspective, we see that their orientation changes from oblique or sagittal to a more coronal orientation in lower levels. There's also a bony prominence emerging laterally, which is the mammillary process. So the mammillary processes are characteristic posterior projections from the superior articular processes of lumbar vertebrae, and they serve as attachment sites for the multifida lumborum muscles. Inferiorly, we have the inferior articular process that fits perfectly into the posterior and medial concavity of the adjacent superior articular facet. And in between, we have the pars articularis. Medially, we can see the ipsilateral lamina. So the laminae of the lumbar vertebrae are broad and thick, but do not entirely overlap one another. In contrast to the thoracic region, a distinct space exists between the lamina of adjacent lumbar vertebrae. We see also how this changes in terms of their more vertical orientation to a more horizontal orientation in lower vertebrae. And from a superior perspective, we see the vertebral foramina that, let's change a little bit the view here to appreciate better the shape. So the lumbar vertebral foramina are triangular in shape, although they're somewhat more rounded in the upper lumbar vertebrae and more triangular in the lower lumbar vertebrae. And let's finalize with the spinous processes. The lumbar spinous processes are broad from superior to inferior and narrow from side to side and project directly posteriorly. There's a posterior inferior ridge which is thick, and it serves as an attachment site for the thoracolumbar fascia, supraspinous and interspinous ligaments, as well as deep back muscles such as the spinalis thoracis, multifidus, and interspinalis. The size of the spinous process tends to get smaller as we move towards the lower vertebrae, and that's the overview of the lumbar vertebrae. The sacrum is a large and complex triangular bone situated at the base of the spine. It forms the posterior wall of the pelvic cavity, and it presents 6 different surfaces: a superior base, an inferior apex, 2 lateral surfaces, a posterior dorsal surface, and an anterior pelvic surface. It articulates with 4 different bones, superiorly with L5, inferiorly with the coccyx, and the ilium part of the hip bones on each side. The sacral promontory articulates with L5 to form the sacrovertebral angle, which is an angle of about 30 degrees from the horizontal plane that provides a useful marker for different lumbosacral procedures. There are 2 lateral projections coming out of the base of the superior end plate that are called the wings of the sacrum, or the alae. The alae articulate with the sacroiliac joints, and these alae support the psoas major muscles and the lumbosacral trunk, which connects the lumbar plexus with the sacral plexus. Over the anterior surface or pelvic surface, we can notice the body of the first sacral vertebra, the second, third, fourth, and fifth. Each body is fused and has a crest at the place of their fusion, which is a transverse ridge. Laterally, there are anterior sacral foramina, total of 4 foramina that have decrease in their diameter as we move towards the lower levels. Again, laterally, we have the auricular surface, which is for each side is going to be the place for the articulation with the ilium part of the hip bone. Superiorly, with this, we see the sacral canal, which is the continuation of the spinal canal or vertebral foramen. And we see the only articular process that is not fused, and that is gonna match the inferior facet of the inferior articular process of L5. Again, the ala and a median crest. We see that the medial crests are the remnants of the spinous processes, in this case from S2 to S4, with S5 not having a median crest. There's an articular crest which is also created by the fusion of the articular processes. And there's a lateral crest, which is the place for the attachment of several pelvic ligaments. We can also identify the posterior sacral foramina, which, as well as anterior, they're the place for the exit of neurovascular components. Anteriorly, the ventral nerves, and posteriorly, the dorsal nerves. And lastly, there's a place for the articulation with the coccyx, which is called the cornu, and is an inferior prominence that comes or that follows the median crest. And that's an overview of the sacrum. This is a right side cadaveric dissection of the upper and lower lumbar segments, medial to lateral and superficial to deep. Superficially, we observe the supraspinous ligament. In a deeper layer, we see the interspinous ligaments in between the thick and short spinous processes of the lumbar vertebrae. Lateral to the spinous process, we see the short lamina with a big interlaminar space. Lateral to the lamina, we see the inferior and superior articular processes. The superior articular process is going to create a facet joint with the adjacent inferior articular process. Lateral to the articular processes, we see this long transverse process. After partially removing the lamina, we expose the ligamentum flavum. The ligamentum flava of the lumbar region is the thickest of the entire spine. Once we remove the ligamentum flavum, we expose the dura covering the cauda equina, and we also visualize the exit of the nerve root, which is covered by a dural sleeve. In this segment, we remove the lamina, we remove the articular processes, as well as the transverse process, in order to properly visualize the intervertebral space with the intervertebral disc, the posterior portion of the pedicle, as well as the course of the nerve roots that run in an oblique fashion. This is a posterior view, superior to inferior, medial to lateral, left side, right side. We see the facet joint capsule. We observe the superior articular process matching the inferior articular process of the superior vertebra. The vertebral lamina, superficially the supraspinous ligament, and on the right side we see the facet joint. After removing the capsule, we see an exposure of the nerve root after removing the lamina, transverse process, and the facet joints. We see the posterior portion of the pedicle, and we see how the nerve root runs in an oblique fashion. There are three segments during the exit of this nerve root. The most medial segment is the retrodiscal segment, the parapedicular segment, and the intervertebral foramen itself. Anterior to the transverse process and protecting the lumbar plexus, we can find the psoas major muscle. This is an anterior view, right side, left side. We identify the abdominal aorta with a couple of its branches. Its bifurcation as a common iliac artery, right side and left side, and a medial sacral artery coming out of the abdominal aorta. The common iliac arteries are gonna give off external and internal iliac arteries. And on the right side, we see the inferior vena cava with external and internal iliac veins draining into this vein. Laterally, we observe the psoas major on the left side, and on the right side, we see the ureter as well as the genitofemoral nerve lying lateral to the ureter. Usually this bifurcation happens at the level of L4, L5, or even L5, S1. This is important when planning to approach any portion of the lumbar region from an anterior perspective, since it might require some kind of mobilization either of the abdominal aorta or the iliac vessels. This is an oblique view. What we're seeing here, this is the anterior portion of the lumbar region with the anterior longitudinal ligament attached to the bodies of the vertebrae, and we see the lumbar arteries that arise from the posterolateral aspect of the aorta and run laterally along the center of the anterior and lateral aspect of the vertebral bodies. We identify again the ureter, the sympathetic trunk, and laterally the genitofemoral nerve. We see the intervertebral space with the L4, L5 disc. We see the left common iliac vein, as well as external and internal iliac vessels. We see a retraction here over the psoas major in order to expose a little bit more of the anterior lateral portion of the vertebral bodies.